hormones have a typical release pattern which varies depending upon various scenarios. So you can have pulsatile hormones which are there. The classical example of pulsatile hormones are growth hormone. You can also have pulsatility with prolactin, LH, FSH, cortisol, and testosterone. Now, the main implication of pulsatility is that if you do levels and the levels are low, that does not exclude that there is a that does not confirm that there is a deficiency, because you can have some scenario where you have done on the nadir level in that regards. But if you look here in terms of pulsatility, how can you overcome this problem of pulsatility in terms of endocrine assessment? Yes, so the one option could be you do a stimulation test like a growth hormone stimulation test or a GnRH stimulation test. Other option is do a pooled sample. So when you do a pooled sample, you take samples at 0, 15 and 30 minutes, and then you mix all the three. You don't do 3 times level and mix it. You mix all and do a single level. So this is the problem of pulsatility we may happen. You may have a diurnal variation. And one of the major axes in which you have got diurnal variation is the hypothalamic pituitary adrenal axis, in which there is a lot of variation, and this forms the basis of evaluation, which we'll discuss subsequently. And most common will be ACTH, cortisol, and estradiol also in that perspective. You can also have a periodic variation, typically in the level of female reproductive organs in terms of the menstrual variations which happen, with the peak of LH which happens here as compared to FSH. And that makes it very, very important to evaluate these hormones in terms of the various time periods. And finally, you've got the seasonal variation. Which hormones tend to show a seasonal variation? And yeah. So that's why in many patients with hypothyroidism, you will see that during winter months, your requirement of thyroid hormones may go up. So this is something which is common. What else? Estrogen, vitamin D. So these are the classical hormones which will change. So reproductive hormones do tend to have a variation in terms of season. Vitamin D and prolactin also tend to change. Now, as far as the various pulsatility and the release pattern, insulin is a major hormone, and we discussed this last time also, that insulin, PTH, the AVP, they are mainly regulated at the level of release. Now, insulin release is a very, very unique phenomena which forms the pathophysiology of both hypo as well as hyperglycemia. Now, essentially, you want insulin to be released in scenarios where you have got enough energy, because you don't want insulin to be there when your energy levels is less, because insulin is going to deposit this in the bank. So you want the insulin secretion to be linked to the intracellular energy status as depicted via the ATP level. Now, if your ATP is high, which will happen in the presence of a nutrient signal like glucose, which goes in via GLUT2 and glucokinase, which we'll discuss much later, you will have production of ATP there. You can also have this coming from the amino acid or the fatty acid pathway via the SCAD pathway and the GDH pathway. Now, as your ATP is going to bind to the potassium ATP channel, and it is going to really ensure that your potassium is not going out. Once your ATP levels is more, your potassium is going to be inside the cell. If the potassium is inside the cell, you will have a depolarization. In that setting, your calcium will enter and will result in the insulin release. So in this way, the body is very cleverly linked the ATP level to insulin release. High ATP, more insulin; less ATP, less insulin. And the main mediators here, therefore, include one, of course, is this GLUT2, the GDH, the SCAD, and the potassium ATP channel, which is there in that perspective. So problems in any of these will result in both hypo and hyperglycemia. So which conditions, Dhwani, will cause hypoglycemia? Yeah. So more activity of the potassium ATP channel, more activity of the glucokinase, more activity of the SCAD pathway or the GDH pathway, you will have more ATP level and more production of insulin. On the other hand, if you have problems in the GCK deficiency, if you have a problem in the potassium ATP in the form of the the other defects which cause the monogenic diabetes, they can also have the similar picture from that perspective. So this forms the basis on that. So nutrient regulation is very, very important from insulin perspective. Now, insulin is also regulated via the neural control. So you've got the sympathetic pathway and the parasympathetic pathway, which has an impact as far as insulin is concerned. So what do beta and alpha receptors do in terms of insulin secretion? Okay, so if you give beta agonist, you will have more insulin. So if you give terbutaline, people used to give, they were causing more hyperglycemia. So you have got antagonistic effect of beta and alpha in that regards. There are other regulators of insulin secretion, including the endocrine. Somatostatin, of course, is the inhibitor. So you will use somatostatin in the treatment of hyperinsulinism. You will have incretins, and we know that incretins are substances which are released via the duodenum in response to oral intake of carbohydrate containing meal, and they are responsible for decreasing the gastric emptying, increasing the satiety, as well as having effect in terms of insulin secretion and glucagon secretion. And incretin based pathway is very, very important in treatment of type 2 diabetes, as we know. Incretin is also involved in the development of one form of hypoglycemia. Yes. So if somebody is post-bariatric surgery, or if you have surgery for the hypertrophic pyloric stenosis, if you have got rapid exposure of glucose to your duodenum, you will immediately have a shoot, and that causes hypoglycemia. So incretin becomes important, and incretin antagonist is being developed, which will be helpful in that particular scenario in that regards. Now, growth hormone also has an impact, as has estrogen, cortisol, but they are less important in that regard. Now, I discussed that when you talk about insulin, and we always say, okay, for these rapid hormones, you've got main regulation, which is happening at the level of release and then synthesis, but it doesn't mean that you have stored a huge amount. You can't afford to keep so much insulin. So the first phase is basically what you get from the preformed insulin, and the second phase is what is coming from the newly formed insulin. So depending upon whether your first phase is defective or your second phase is defective, you will have either postprandial hyperglycemia or a fasting hyperglycemia. Which one will cause fasting hyperglycemia? If your preformed is going to work mainly in terms of the meal response. So you have used that and then you're not forming well. So your hepatic glucose production, and so your basal insulin. If you look at, like, you can think of it basal bolus. So if you have a problem in the first phase secretion, you will have more of a prandial hyperglycemia. While if you have a problem in terms of second phase, you will have a problem in terms of the fasting hyperglycemia, which is there. So now you have a 2-month-old boy with failure to thrive. Birth weight was 2,500, now 2,800. Hepatomegaly, myopathy, and weakness. Sugars are very high. HbA1c is high. Triglyceride is very, very high. So what do you think is happening here? So this is neonatal diabetes. Definitely looks more likely to be a permanent because you have a later presentation, and you specifically mentioned about muscular weakness. Hypotonia, basically. So which neonatal diabetes you will have lot of neurological involvement and hypotonia. One, of course, you can say it is because of the very poor sugar control now, but if it's a clue to diagnosis. So you have got developmental delay, diabetes, neonatal diabetes with developmental delay. So it's a potassium ATP channel defect, the Dent syndrome. So this, again, as I discussed, is a scenario wherein you will have a KCNJ11 mutation, and they will respond very well to sulfonylurea. So you need to understand whether there is a problem in the sensitivity that we discussed about glucokinase, problem in the transcription factor like HNF1 and 4 alpha, and then this in which you have an issue in terms of the KCNJ11. Now, we discussed that time that KCNJ11 tend to require much more glibenclamide as compared to HNF1 alpha. Why? Because here you are actually already having a problem in that particular region. So you need a supraphysiological dose to take care of it. While in the case of HNF1 alpha, basically what the problem is that your potassium ATP is completely working, your HNF1 alpha is less active. So if you overcome that less activity, even slight response will result in insulin production. The other mechanism is there in that regard. 10-day-old girl with hypoglycemia and glucose infusion rate is higher, around 14 milligram per kg per minute. So this of course means more of an increased utilization. Ketone is negative. So what are you thinking of? So this is more like a hyperinsulinism most likely because your GIR is also very, very high. Reducing substance is negative. The insulin level was found to be 3. So this is significant. So this again is an important cause. What is the most likely thing you're thinking of here? You will need to know what will give you, which history will give you the clue. So that is too late now. 10 days unlikely for persisting birth weight. So whether it's SGA or LGA. So there was a glucagon response, hyperinsulinism, and it was found to be potassium ATP because it was a macrosomic child. So we have got two extremes, one in which you have a problem in the potassium ATP sensing, in that you are sensing less. When you're sensing less, you have got less insulin. If you sense more, you will produce more insulin. So these are the paradoxical response in that regards. Now, PTH is also an important hormone which synthesis involves multiple steps. And we know that PTH is basically produced as a pre-pro-PTH, which then is converted into PTH, which is either degraded or secreted. So you cannot keep the native PTH for a long time. So basically you can keep pre-pro-PTH, but not PTH in that regards. And one of the major regulators of PTH release is magnesium. And this is something which we know very, very clearly, that both magnesium as well as phosphorus. So if your phosphorus is high, PTH will be? No, if your phosphorus is high, PTH will be high. So it is stimulate, and same if your magnesium is high, your... Okay, so if that's a very interesting scenario, through what mechanism? It will act as a calcium receptor, and the body will sense it as adequate calcium levels. Yes. So magnesium and calcium, they are both basically ions which are similar in structure. They've got 2+ structure, so they can bind. It may mimic like calcium. So if you have got too high level of magnesium, you will have hypocalcemia with hypercalciuria. So it will behave like calcium sensing receptor activating mutation. But if you have magnesium deficiency, you will again have hypocalcemia. Why? So PTH release and PTH action, both can be affected in that regard. So magnesium is very, very important in that regard. Now FGF23 and calcitriol will inhibit PTH release, because if you got more FGF, both have a same effect. So you want to really counter that in that perspective. That becomes important from that regards. And of course, if you have got calcium working on the calcium sensing receptor, it is also going to inhibit your PTH. So 10-year-old boy with seizures with ionic hypocalcemia, phosphorus is normal, PTH is on the lower side. No response to IV calcium. What are you going to do here? That's 0.1. Yeah. Much higher. Yes. So this looks like a hypoparathyroidism. So you will do a parathyroid genetic study or a scan. So at 10 years, you will look at maternal history. So we were just discussing, if you have somebody who had refractory hypocalcemia, before you do other things, you should look for magnesium. That becomes important. And here you need to look at the magnesium level in that regard. Now, a trick sometimes which happens is that if you have hypoparathyroidism, what will happen to magnesium levels? So you may also have hypomagnesemia. So you may have a dilemma whether this hypomagnesemia is causing hypoparathyroidism or hypoparathyroidism is causing hypomagnesemia. So we had a very interesting case in which we have the child presented with recurrent cases of refractory hypocalcemia. Magnesium was around 0.4 to 0.6 milligram per DL, which is way low, and PTH was like 10 to 12 in that regards. So in that scenario, you need to understand what is the primary pathology. So you see so many cases of hypoparathyroidism, you don't see that low level of magnesium. So it's actually the magnesium which is causing the PTH to be low, which becomes important to understand. So from that perspective, you need to know that anybody who has a refractory hypocalcemia, think of hypomagnesemia. So if when we talk about hypomagnesemia, we'll talk about hypomagnesemia has a very interesting relationship, inverted J relationship. If the levels are very, very low, you will have impaired PTH release and action. If the levels are slightly low, you have a main problem of release. Then you will have an optimum level of around 1 to 1.56, something like that. But if the levels go high, it is going to start acting on the calcium sensing receptor to cause hypocalcemia. So hypoparathyroidism and hypocalcemia. So an inverted J-shaped relationship is there. What about AVP? And we already discussed that you've got pre-pro AVP. Again, the release basically is regulated via multiple factors. And as for insulin, you're linking insulin to ATP levels. AVP has to be linked to osmolarity. Now, which is the most closely regulated biochemical parameter in the body? Sodium and osmolarity are the same. So if we talk about glucose, body is able to tolerate a level. We say, okay, we are okay with 90 to 130, 80 to 140, there's no problem. Or if the level goes below 60, you've got a lot of responses. So there is a margin of around 100% there. But if you talk about osmolarity, what is the margin there? So at 280, you have got no AVP. At 283, 284, your AVP suddenly starts increasing. 295 to 300, the levels are very high. So it's less than 10%. 1 to 2% change also will have an impact, and maximum variation is 10%. So osmolality is a very, very important regulator of the vasopressin regulation. So you've got osmoreceptor, which regulate the osmolality using the organs which are basically the circumventricular organ, the organ vasculosum lamina terminalis, and the subfunicular organs which basically regulate osmolality. And if your osmolality is more, you will have greater amount of AVP release which is there. You also have a parallel regulation of AVP using fluid. Now, fluid regulation and osmolality regulation, what is the basic difference?
We require much larger difference in the fluid level to cause the release of ABP, but when there is a like 1% different change in the osmolarity, there is a release.
Yes, so fluid deficit, you will need to have severe dehydration, 10%, 20% dehydration, then your AVP comes into the picture. The other big difference is that the amount of AVP released, which is there for the osmoreceptor response, is less as compared to the amount that will be released in the form of hypovolemia. That's like a dying situation. You lost 15-20%, you want everything. So then your vasopressin is not going to act on your tubule or collecting duct to cause water to come in. It is going to act directly on the vasopressin receptor to cause vasoconstriction. So then it becomes a vasopressor rather than an antidiuretic hormone. So volume deficit will going to really have a much bigger impact. But if you have a combination of volume deficit along with osmolality, the effect is more or less. Yes, so if you have hypovolemia, you may have greater amount of secretion of AVP, and this can cause confusion. A very interesting corollary. The whole talk is more of linking all the things that we have talked till now in endocrinology. A very interesting scenario is the impact of hypovolemia in congenital adrenal hyperplasia and the lack of replacement of mineralocorticoid or inadequate mineralocorticoid replacement leading to higher glucocorticoid replacement. So if you are having persistently high 17 OHP levels despite a good dose of hydrocortisone, you say, okay, I'll check the PRA level. whether the mineralocorticoid supplementation is good or not. Now, what is the link between mineralocorticoid replacement and hydrocortisone requirement?
We know about hypocorticoid. So ABP will be.
So you're saying the other way around. So if you have got inadequate this thing, you will have hypovolemia, and hypovolemia will trigger, and AVP will trigger.
Increase the glucocorticoid requirement much more.
Why? It will increase the ACTH level. So ACTH is regulated via CRF and AVP. So that becomes important. And cortisol suppresses both CRF as well as AVP. So this whole loop is probably fixed on that. So if you have got less mineralocorticoid, you have got hypovolemia, you have got high AVP because of this mechanism, which causes high ACTH, high 17-OHP, high glucocorticoid requirement, which is there from that regard. So this becomes important, and this is the regulation as far as the fluid is concerned. And then, of course, fluid are sensed via your sensors, which are there in the heart, which is sensing through the ANP axis, as well as the carotid sinus, where the effects will be there and regulations are there. There are also non-osmolar signals which control AVP secretion in the form of nicotine, apomorphine, and caffeine. So if somebody is drinking a lot of caffeine, that can really have an impact in terms of AVP responsiveness, and we need to avoid that when you're doing a water deprivation test. We say for at least a day or two, you should not be taking high caffeine feeds in that regard. There's a very interesting relationship of cortisol and AVP, and this is what I talked about from CAH perspective, but I gave you a hint that cortisol is inhibiting. So if you are cortisol deficient, you will have?
So there is a water retention.
Yeah, you will have more AVP, you will have a SIADH-like state. If somebody has DI and he develops cortisol deficiency, so he has DI minus SIADH, which becomes normal. So if you have somebody who has DI and who doesn't need any more AVP now, the first thing you should think of is cortisol deficiency. So all this linkage will come up when you understand the physiology well from that regard. So cortisol inhibits AVP, and therefore if you have cortisol deficiency, you have SIADH like picture. So this is what we're talking about. 10-year-old girl with craniopharyngioma post neurosurgery has polyuria, was given vasopressin and developed hyponatremia. So what do you think went wrong in this regards?
We expect them to go into a care followed by SIADH phase. So here, initially managing the just fluid could have helped instead of standing.
So this is a very, very significant scenario which is there. So you will have initial cell swelling, which is going to cause this transient DI. Then you've got release of AVP, and we said AVP is a huge store in the brain. You release it, you develop SIADH phase, and then you can have a permanent DI. Not necessarily that you've got this entire triphasic response in everybody, but it can be a big headache in that regard. And somebody gives them Minerin or something, that really causes a huge problem from that regard. So this could be a SIADH phase, and avoid AVP. Now, growth hormone also is an interesting scenario in terms of how growth hormone is regulated. You've got a stimulatory factor, which is a growth hormone releasing hormone. And then you have got basically an inhibitory factor, which is somatostat. So GHRH acts by the G protein coupled receptor to produce pre-growth hormone, while somatostatin acting by the somatostatin receptor will cause a problem in terms of growth hormone release. So one is that production, the other is that release. So these pulses of growth hormone are largely due to somatostatin or because of GHRH. So when your somatostatin level goes down, GH is released. When it's high, it is not released in that regards. Now, ghrelin, and we discussed this, that ghrelin is basically a thing which is secreted by the stomach when you are hungry. When your stomach is less distended, you secrete ghrelin. When you are full, you don't secrete it. And this ghrelin is an important stimulus of growth hormone production, mainly to counter hypoglycemia. You don't want somebody hungry to grow more. You want hungry to get more glucose, more fatty acids, which is going to come from the growth hormone. So this is what it is working like, causing the release. Now, thyroxine is also important as far as release is concerned, as is estrogen, which is the main mediator of pubertal regulation. And that's why we talk about the role of priming of steroids during the growth hormone stimulation. in that regards, and cortisol is something which inhibits growth hormone secretion from that regards. IGF-1, of course, will have an inhibitory effect as part of the feedback pathway. So there are multiple regulators as far as growth hormone levels are concerned, which are going to regulate this whole process from that regards. And this results in this complicated pulsatile secretion. And we all know that we should never be doing a growth hormone at a basal level unless you're thinking of a growth hormone resistance in a very, very clear-cut scenario. Now, release can also result in pathological findings. And as discussed, if you have more store, you may have disorders of excess because of release. So 6-year-old boy with fever and neck pain, FT4 is high, TSH is low, there is no goiter or eye sign, and the pain is excruciatingly significant. What are you thinking of? Yeah. And which type of thyroiditis?
It is so severe, might think about a acute thyroiditis.
Acute is extremely like that, you can't miss. That's like you can't even touch the this. It will be extremely red. So it is more likely to be subacute. In subacute also, we have seen a couple of cases recently. There is a lot of tenderness which is there in these cases as well. And if you do a thyroid scan, you will find that there is a no uptake, or you do a TRAB antibody, this will be negative, which is an easy test you can do immediately to get this clue of diagnosis. ESR or CRP, that will be very, very high. Like recently, today we saw a patient with 84 CRP, which was there. So there was severe tenderness. Now this case is very interesting because he also gave you a past history of recurrent similar illnesses, which will make what you talk about acute thyroiditis likely. So while I will think subacute also, but if there is excessive tenderness and there's a past history, then this could be a acute thyroiditis because of a sinus, a connection between the thyroid gland and the intestinal tract. So you've got multiple recurrent infections happening, the pyriform sinus.